All right, so I think we have had such a long time been using this drug. I think we have accumulated a lot of experience on side effect, not only for how often do they occur and also how do we manage them. So we live in a very progressive world. We had by far the BTK inhibitor that's leading is ibrutinib, but the ACP-196, BGB 3111, and they are quickly coming up into clinical trials. ACP reached the phase 2 trial, and BGB is phase 1, and then added cohorts. And then other compounds are coming up too, and AVL 21292 has been stopped for lack of opportunity efficacy. So that's not all. There's more. There's more, ibrutinib. Then this one stopped. Then ACP-196. There's numerous BTK inhibitors coming up. Of course, the single agent activity so far is the best for ibrutinib, but they are here. They are here with the cost. The efficacy come with a little cost. For example, the work on the other off-target effects to induce side effects. So, for example, the work on the adhesion molecules they cause lymphocytosis. Lymphocytosis in the relapse setting in the mantle cell lymphoma usually is very mild, but lymphocytosis in the newly treated patients who newly previously not treated patient at frontline could be very severe. And this is a new phenomena. We cannot see that because we see only a few side effects, we should forget it. I'm very, very cautious when the WBC for mantle cell lymphoma is over 100. I almost always do pheresis, and even below that, I would like to monitor for hyperviscosity. You ask the patient how they're breathing and how whether they have infiltrating in the lung, whether they have bleeding in the retina, you have their headaches or severe fatigue. You need to watch out the symptoms. For CLL, probably the hyperviscosity syndrome is much less because of a different biology, and also the fact that the CLLs, like Mark pointed out, is much smaller than the mantle cell lymphoma. But I would still exercise caution. If you treated a Waldenstrom's macroglobulinemia, the hyperviscosity almost always occur with the big molecule IgM, but it does occur with the IgG and IgA, or sometimes in myeloma. Very rare though. And so atrial fibrillation is not to be scared of. If you have a patient who has prior atrial fibrillation, very likely if you treat the patient for more than 2 years, the atrial fibrillation will at least recur intermittently. What I have been doing I work with the Texas card. For half of the patient, we do nodal ablation. For the other half, you just anticoagulate and rate control with amiodarone. So then there's a platelet inhibition by ibrutinib. This is also important. Ibrutinib is a bleeder. It acts like a aspirin. So if the patient does not fall, does not have trauma, usually the bleeding is always mild. But the median age for mantle cell lymphoma is 67 years old. So the elderly people, they are very, very at risk for fall. And this is a major geriatric issue. Do not underestimate the risk for fall, because 50% of people will fall, and most often in the bathroom and with the head hitting something. So I have a patient on the clinical trial 1104, and that patient fell off a nightstand. He hit his head, developed a severe subdural hematoma, and we have to stop the medicine. Then he was admitted to the hospital. They surgically evaluated that hematoma. Then he had a aspirated pneumonia in the hospital. So then by the time the pneumonia is cured, the mantle cell lymphoma has come back. So he died from the, I would see, risk of complications of bleeding. And also, the patient may have a rash. They have usually two types of rashes. The first rash is a EGFR mediated rash, and that's usually mild in relapsed patients. And the second rash is a bleeding rash. It's almost a combination with a EGFR rash that with the platelet inhibition, the patient bleed into the rash. Very, very typical. Seldom is a problem. But for patients with newly diagnosed mantle cell lymphoma that's not treated, we are moving rapidly from the relapse setting to the frontline setting. All the biological agents, especially ibrutinib, the rashes could be very severe. It looks like a Steven Johnson syndrome. The whole body covers, and you stop the drug, you give the patient dexamethasone, metal dose pack, but the patient cleared the rash, then you stop it, you stop the steroid, you re-challenge the patient have another rash. I never stop the therapy due to no matter how bad the rash is, but usually the rash turns to get better. There's a process of desensitization. So do not be scared of the rash, but you have to tend to it because the patient has severe itching. This is the side effect, the major side effect from all the trials, including mantle cell lymphoma and CLL. You can see the severe grade 3 or 4 side is usually neutropenia, and thrombus is bone marrow related. So those are usually, these are regardless of relationship to the study drug. So this is mainly going to reflect the amount of myelosuppression from prior many chemotherapy, stem cell transplant, and all that, copper CVAD. But two side effect does stand out. Diarrhea, it is related to the ibrutinib. Ibrutinib causes diarrhea almost. I never have to treat any patient for dehydration. It usually is not a bad diarrhea. You don't usually really pay much attention to it. A soft diarrhea. I never had a hydration. I treated hundreds of patients, never had a dehydration. The other issue is the pneumonia. I think the mechanism for ibrutinib, it does antagonize the immune system. It does cause increased infections. If you have more time, you will see the non-neutropenic pneumonia and other infections is a severe problem. So I have patients, more than 30 or 50 of them already past the 2-year mark. The infections usually increase. Usually it's a sinusitis, upper respiratory syndrome, and a pneumonia syndrome. So I sometimes have to stop the therapy because of intolerance. If you don't stop the ibrutinib, it keep occurring without the stop. So I frequently test the IVIG. If there's a level, I use IVIG very excessively. So of course, there's a drug-to-drug interactions. You have to follow the guidelines very closely, otherwise you'll get into trouble. I have a patient who has CML and also MCL. They are on Gleevec. They are on this medicine, so we have to reduce the drug to half the dose for each. The side effect really gets worse when you combine with the other therapies. So not much. This is a combination with a rituximab, and of course this is a 50 patient. The efficacy is unmatched. Any regimen ever studied in mantle cell lymphoma, over response rate 88%. And the major side effect is that when the ibrutinib will drive the cells lymphocytes to high, and you give regular speed rituximab, the patient have severe chills, hypertension, hypotension. So you really have to slow down the rituximab, pre-med with dexamethasone. And for a number of times, I have to admit the patient to the hospital for a slow rituximab at 25 mLs per hour for like 36, 72 hours. So that's how I deal with it. But this is especially true when you are moving the combination studies in the front line. There will be dramatic, extreme lymphocytosis. You put some rituximab, they crash because these cells are easier to die than the regular lymphocytosis patients, because those are the cells that are driven out of their home environment into the peripheral blood. They are more vulnerable to a second attack. And if you do attack with the rituximab with the regular speed, you get a severe cytokine storm and tumor lysis syndrome. So be very careful in the future for that. The side effect, at the time of the ASH presentation was not major, and it's mainly grade 1 and grade 2. But with time, infection rate does pick up. So my time is up because the other drugs are not worth. There's other drugs, ACP-196, and if you treat the outpatient, you will see the problems. The headache is very frequent, and diarrhea and increased fatigue. When I was in the earlier phase of clinical trials, a patient asked me for ibrutinib, what's the side effect? I said there's no side effect, because if in the first 6 months you don't see side effects. So the median follow-up for those for CLL probably lives longer, but for mantle cell lymphoma is still very short. So the side effect does occur. There's headaches is a major thing for this one. Diarrhea, almost a class effect. So other side effect, I would assume it can be safely assumed that this side effect profile will get worse with time. Another medicine is a BGB 3111. There's one number missing there. So you can see the side effect is also, there's a PTKI, there's upper respiratory infections, there's a constipation, there's a diarrhea, so if you see these patients do not have infections, I would doubt, because the patient received prior 2 or 3 prior lines of therapy, their bone marrow affected, they are myelosuppressed. Of course, infections will never go away. So the claim that the ACP-196 BGB 3111 is safer than ibrutinib is not fair so far. It needs more time. Thank you.
So, Michael, I just want to say that we've been using ibrutinib in primary CNS lymphoma, and we have now seen 4 Aspergillus pulmonary infections. Now, these people were relapsed, and so they were all on steroids, but this is not something you normally see. And so I too wonder whether or not this drug, especially in the context of steroids, which is something you see with this particular disease, may in fact increase the increase of some pretty severe infections.
William, I totally agree, and I echo that point. And I also am a little concerned, and I really suggest an approach to this. Rather than downplay the infection rate, we should face the infection rate by really addressing it. Why? Because if you admit your drug could cause, because of the mechanisms of action, it's inhibit platelet and neutrophil function, and it's antagonized the immunity. So the infection will go up in this in this population of heavily treated patients. The infection will go up. If you don't start addressing that, don't develop the guidelines, the patient will start dying on it. There will be really bad press. So how do we do that? Number one, we need to aggressively reduce the drug dose. We need to check IgG. If they are low, we do give IVIG. We need to have a very low threshold of treating them with antibiotics. We should have a threshold of stopping the drug, put the drug on hold. And if the patient keep coming with infections, we need to take the patient off the drug. We need to pay attention to those people who are at high risk, COPDers, history of prior fungal infection, including pneumonia, and those things.
So one thing that is interesting is that ITK is responsible for the migration of lymphocytes to the lung, and in asthma animal models, you can block asthma by giving inhibitors of ITK because it prevents lymphocytes moving toward the lungs. So we have, or I have come up with this idea that it's possible that what we're seeing here is because ibrutinib does inhibit ITK, we may be, preventing proper lymphocyte trafficking, and we're actually modeling that now.
That may be part of the reason why we keep getting lung infections.
I have a question. Dr. Wang, uh, although the ibrutinib-induced diarrhea, as you pointed out, is not severe, maybe bothersome, I've read and I've done in 3 cases that it say that you have to separate the ibrutinib dosing from meals. Is that correct? That prevents diarrhea? Because I've done that and I didn't see the diarrhea. And the second one is about the hypertension. I think, as someone mentioned earlier on, that they start to see hypertension as a side effect, and you didn't mention anything about it.
The hypertension? Hypertension. Well, I do see a few patients with hypertension, and they're not very common, but they're very easily treated with adjusting their blood pressure medicines. And so your second question is about diarrhea. Diarrhea. So I usually give the patient some what you call it, Lomodo, but there's a drug very effective. I know I use that for it will come back to me. I'll promise you it will come back to me. If you use that drug, the diarrhea will be gone. So it will come. But I want to share with you the Wang cocktail. I have a Wang cocktail to prevent the rash. The Wang cocktail have 3 over-the-counter drugs: Zyrtec 10 milligrams, Zantac 150 milligrams, and L-lysine. L-lysine is a supplementary drug. I could oftentimes reduce the rash by 30 to 40%. Sometimes the rash is mild, it does not occur. So that's my first line of therapy for rash. If it doesn't, work, I'll add a middle dose pack, and it still doesn't work, I add dexamethasone 20 to 40 weekly.
You said that in mantle cell lymphoma patients in front line using ibrutinib have a higher lymphocytosis than in relapse. Is there any explanation for that?
I think the newly diagnosed patient, their EGFR receptor, they have never been exposed to chemicals. I think the EGFR receptor number and sensitivity goes down with the prior therapies. So if the patient is newly diagnosed, the EGFR receptor may be greater in number and more sensitive. The second issue is that the lymphocytosis is pronounced in newly diagnosed patients because those newly diagnosed patients always have much more tumor load than the relapsed patients.
Also, go ahead. No.
Okay. It's a short question. How do you deal with neutropenia? Can you lower down the dose, or do you just give growth factors? Or
growth factor, if the patient is responding to therapy, I try not to lower the dose. I sometimes use ibrutinib while I use the growth factor. So.
But is it acceptable to lower the dose, or should we just stop and then start it again?
I almost never lower the dose because of neutropenia.
I just wanted, because your last comment about ACP, of course the follow-up is not so long, so we don't know. Mm-hmm. The overall impression is definitely that, for example, bruising is not happening. So patients are not complaining. That with ibrutinib happens in the first days or weeks.
Yes.
Most of the cases, which is of course grade 1, 2, no problems. We keep on, but it's something the patient notices. So the only thing that is really bothering the patient is the headache, which is definitely something that is not happening.
The headache is ACP.
With ACP. Yeah. So that's something, but the bruising is definitely we don't see.
The bruising thing is if the patient does not fall, does not play contact sports, does not ride bicycles where they can hurt their heads, the bruising is not a major problem.
I don't know, because in CLL I mean, at least 50% of patients have
So
something.
for
So really,
the
without doing, in
the other
Italy we
issue-
don't play football, American
right,
football, you know.
they
play
ride
tennis.
motorcycles, you know. So the other thing is that for the small procedure, we stop the drug 3 days before, 3 days after, and on the day of, so 1 week. If the patient has a major surgery and we like a colonoscopy with so many biopsies, we would stop the drug 7 days before, 7 days after, on the day of, so for 15 days. Okay.
So Paolo, I just want to ask you about the bleeding. So when I go read the New England Journal of Medicine paper that just came out in ACP 196, if you add up all of the bleeding adverse events, their rate is 54%. So I keep hearing this statement that ACP 196 has less bleeding, but the data in the New England Journal of Medicine paper doesn't support that. I mean, the data says that it's 54%. If you went and read the same New England Journal of Medicine paper written by John Bird for Resonate, it's 44%. So I'm missing something here in terms of this whole idea that ACP 196 has less bleeding, because their trial data would say it has about the same. I don't know where.
I mean, we'll find out. I mean,
I guess we'll have to wait and see.
There's a randomized trial